We are honored to welcome the moderator for Beyond Diabetes, Professor Dr. Rakesh Sahai, endocrinologist, Professor of Endocrinologist at Osmania Medical College and Hospital, President at RSDI, and South Asian Federation of Endocrine Societies. He has 250 plus publications and 6,000 plus citations, and he's the recipient of the Best Teacher in Medicine at 2018. So Dr. P.V. Rao, who is a former senior professor and HOD, Department of Endocrinology and Metabolism at NIMS Hyderabad. He is a director at Diabetes Research Center, Panjagutta, and he is the president-elect for Indian Medical Association, Hyderabad North. He is the first to publish global gene expression profiles in Asian Indians with diabetes and proteomics of diabetes in human urine. He is known for compassionate, patient-centered care, combining the latest medical advancements with personalized treatment plans. I would like to welcome Professor Dr. P. Srinivas Rao, endocrinologist, DNB Endocrinology, Diabetes and Metabolism, MBBS from Kakatiya Medical College, Warangal, MD General Medicine, and he is widely regarded as a popular and trusted endocrinologist. I would also like to welcome Dr. Venkata Rakesh, endocrinologist. He is a consultant endocrinologist at Sanjeevani Hospital. He has multiple original publications in peer-reviewed journals, including Indian Journal of Endocrinology and Metabolism, Journal of Clinical Densitometry, Indian Journal of Surgery, and JCDR. I would also like to welcome Dr. Sandhya Jalapu, endocrinologist, DM Endocrinology, FRACP, Australia, and she has done her MBBS from Gandhi Medical College. She completed specialist endocrinology training in Australia at Princess Alexandra Hospital, and she has been admitted as fellow of the Royal Australian College of Physicians.
We also have with us Dr. Rohini Kasturi. She's trained in the US. She's practicing endocrinologist at Star Hospital in Hyderabad at Nanak Ramgura. So welcome, Dr. Rohini. So welcome to all the panelists. We have an excellent panel here with experience from across the world, and they are all practicing in Hyderabad and Vijayawada. Dr. Meher is from Vijayawada, and we are going to discuss about management of diabetes. Because if you look back at what has happened in the space of diabetes management over the last 3-4 decades, there's been a lot of change. We have got several new medications. Today we can say that we have got 8 different classes of medications. So you can choose between 8 different classes of medications. I will not list out all of them, but everybody knows metformin, sulfon. Earlier it used to be, when probably when Dr. P.V. Rao started his practice, it was like only metformin and one of the sulfonylureas. And even when I was practicing earlier, it was like that. But then we have ourselves, many of us ourselves have seen the entry of so many new classes of drugs. We saw the glitazones coming in, then we saw the gliptins coming in, then we saw the SGLT2 inhibitors coming in. We have seen the GLP-1 analogs coming in. We have seen molecules like imiglamine, acarbose. So many molecules have come. We have now 8 different classes of drugs, and we have to choose wisely to bring our patients to their glycemic targets. And and also our targets have been changing. What we have been earlier looking at, there was an era when we used to just think about glucose control. Earlier it used to be glucose control. What we would say is in the early 2000s or even in the 1990s, it used to be like glucose control based on what the DCCT said and the UKPDS said. We knew that. We said that okay, everybody should be brought to less than 7% or even less than 6.5 possible. And then we started having the impact of hypoglycemia. Accord study showed that, and then that was a phase when everybody was worried about having drugs which are safe and not causing hypoglycemia. So that was one era. And then then came the era when we said that we should have drugs which are safe from the heart. Should not damage the heart. When we had the rosiglitazone saga coming in 2007, and after that everybody was looking at drugs which are safe for the heart. And now we are in this new era where we are saying that we have medications which can protect the heart, protect the kidneys, and actually modify the disease course itself. And so that's how the practice of diabetes has changed in the last 2 or 3 decades, and we have been witness to so many new things happening in these last several years. So what I would like to discuss, we'll bring out some of these issues I would like to discuss. So today we are, saying that we should be focusing, not looking at HbA1c alone, looking at organ protection and looking at drugs which can provide that. So there's a lot of discussion. I'm sure everybody here in the hall would have heard many lectures, many sessions where we discussed just about SGLT2 inhibitors and GLP-1 analogs. So I would like to ask our most experienced panelist here, Dr. P.V. Rao, about how far he thinks is glycemic control still important or not important today.
Thank you, Rakesh. First of all, I thank organizers for continuing to give me this kind of opportunity after so many years. I've been sitting on the stages for the last 40 years now. So I'm like I've seen the evolution of diabetes medicine in India. I have seen all those senior people, Professor B.K. Sahai, Dr. Sachinarayan Reddy, Shyam Sundar. Now I'm seeing all these young American endocrinologists,
Australian also, yes.
Australian endocrinologists, British endocrinologists, and two Indian endocrinologists also, purely Indian from Usmania and Kurnool Medical College. It's nice to see the amalgamation of all sciences from all over the world. It's nice that I'm the luckiest person to witness the evolution of diabetes medicine from American people, British people, Australians, Indians. So thank you so much. Today the question is, how relevant is glycemic control?
HbA1c.
And HbA1c. So we have seen the origins of glucose estimation. Glucose estimation from 1970s, it has evolved a lot, starting from Felling-Wu to so much has evolved in glucose estimation. Glycated hemoglobin also come in our days. Glycated albumin, glycated proteome, glycated proteins. So much of glycation. I'm talking about glycation, not about glycosylation. Glycosylation is entirely different. Don't mix up glycosylation with glycation. So much of things have happened with glycation. I have personally witnessed how these things have evolved starting from 1970s. So of late, when the CGMS has entered, I'm not involved in CGMS. I have done hundreds of CGMS myself, but I'm not involved in the invention or development of CGM, but I am involved in the previous inventions and developments of glycation part, glycated albumin, glycated protein, fructosamine. I was involved. So now with all this information, what I have gathered in last 40 years, I have a feeling that somehow the whole world is trying to downgrade glycemic control. If you take the example of our American Diabetic Association consensus statement, which they have been releasing for last 5-6 years, you have seen the glycemic control is pushed to 3rd or 4th ranking. The first is atherosclerotic vascular disease, nephropathy, then obesity, then glycemic control. These are the primary objectives of managing diabetes. That means you are treating diabetes for preventing cardiac problem, preventing nephrology problem, reducing their obesity, then you are thinking about glucose control. Accepted? That is the way. But 1 week back, 10 days, 7th of June, the ADA, I did not attend, but I have seen the slides. ADA EST has brought down a consensus statement, and then they have released a draft slide, which will come in the 2027 ADA. Then luckily, they have approved glycemic control again in the front. After 6 years, they have brought glycemic control to the front. Then again, they have put all the other things. The primary objective of diabetes control, we don't know. For 6 years, they made it a third in the line. Now they are going to make it first in the line. So people have been playing with glycemic control. But I was also involved in UKPDS, 1983-84, I was there when UKPD started in England. Then I was the person in charge of Indian Council of Medical Research long-term follow-up of NIDDM ICMR study. So with all this information, what I found is that for some reason, hemoglobin A1C of 7% target will help you in reducing the nephropathy, okay, neuropathy, okay, by 40%, but it will not do anything for the major heart disease, okay, UKPDS type 2 and DCCT type 1.
Yeah.
Okay. So in both these largest studies of diabetes in the world literature, in which I was also involved, both in DCCT as well as UKPDS. So we have seen now it is almost 35-40 years of follow-up. Things have been followed for about 35-40 years. So the original data where they have targeted a glucose control by reaching a target of HbA1c of 7% is not going to be the same now. After some 10 years or 15 years of follow-up, gradually there is some deja vu phenomena. They say that, okay, so some memory power or something. So initially when the HbA1c is brought down to 7, they have found out some benefits, but the benefits are no more lasting. So 40%. That means I'll give you the other side of the coin. 60% of the people, in spite of the best efforts in DCCT or in UKPDS, have not been able to reduce their renal problems or neuropathy or coronary artery disease. So keep in mind that it is not glucose alone, but something else, not just HbA1c target of 7% alone, but there is also, it's also important that systolic hypertension control is as much important or even more important, or obesity, weight reduction is more important. You can stop me.
Yeah.
It's okay?
No, it's
So now, no, what is there? Old people will go on talking. we are used to giving lectures without slides, without this kind of decent environs also. So you can stop me.
So we'll come back to you, sir. We'll come back to you. We are not stopping you. We will come back to you. So what we are saying is that you have brought out very important points that, although we know that, we have a lot of medicines which are providing cardio protection, renal protection and all that. But if you look at all the studies which are done with these molecules, wherever you had the cardio protection, you had the renal protection, or you had the benefits you are seeing, they all happened when the background HbA1c is maintained well. So all these trials, you didn't have people with HbA1c of 9% or 8.5% who were getting these medicines and were able to get the benefit. They got the benefit only when their HbA1c was kept at about 7%. The target was all in these trials. There was T2 target trials. You had SGLT2 inhibitor added on, but the basic premise was that the HbA1c should be kept at 7% with whatever medication other than this you had to adjust. So you didn't adjust these medicines, but you adjusted all the other medicines. So that was the way these studies were done. So obviously the benefits that you get in terms of all these protection is going to happen only with HbA1c of 7%. So it is important that we shouldn't forget that. So on that context, let me just quickly ask a few questions on some of the older molecules, what their status is, because today, we have a lot of discussion on the newer molecules, and I'm sure many of the younger members of the audience would not have heard about the older molecules. They're not sure whether we should use them or not. So I'll ask Dr. Meher Gautam how he feels about the SUs. Do you still use the sulfonylureas, because many people now don't use them as early in their management. So where do you place them? How do you see? How do you think that they're going to continue to be there in the management of diabetes, or they're going to be phased out?
So first thing is right now the main management is all about gliptins and SGLT2 and metformin. These are the first line of drugs which most of you have been seeing. But the point is that the patient comes to you first time in the OPD. The A1Cs are more than 8, or probably 9, or even 10, 11. So you are not going to get the sugars to control with these drugs. These drugs are good in the paper, but the A1Cs you get under control is max is like 1.5%. But you need to get the sugars rapidly, at least for the first 1 month, so that the patient can have a good glucose in the first month. So that time the sulfonylureas are going to help you. So these are the most potent at the present this one. So whatever benefits or issues they have with the diabetes complications is a different thing. But if you are talking about terms of glycemic control, sulfonylureas really work. So we have glimepiride, glycoside, and these are the two things usually the most commonly used. But do consider them in one of the in the first treatment. See, most of the prescriptions which you encounter for the patients, patient has A1Cs of 9%, comes to you. The patient is being put on DAPA or gliflozins with the metformin. So the patient is going to go into euglycemic ketosis. He'll have problems with those SGLT2 inhibitors. So do consider sulfonylureas, get his sugars under control first to a reasonable level. Then you can try all your gliptins and things which are associated with cardio, kidney and metabolic benefits.
So Dr. Maher Gautam says that he uses them early and gets them to control, and then starts and then down titrates their role and puts in other molecules. I would actually put it the other way. I mean, I would rather use a gliptin and metformin, get them under control. If they're not getting under control with that, then I would use a sulfonylurea. And many times, I mean, I would say I still use SUs, and I'll take quick views of the others also on this. I would say I still use SUs in maybe about 60% of patients still are on SUs. And the newer patients, probably it's not like, unlike earlier practice, we use them a little later as a third line or fourth line agent. And one interesting observation that I've been seeing is that I've been using them to, keep the fasting under control. Many times you use these triple combination of gliptin and SGLT2 and metformin in the morning. They give very good control in the daytime, but the fasting always remains high. So I use a small dose of SU in the night along with metformin, and I find that works very well. So I just want to quickly have views from Dr. Venkat and Dr. Sandhya also about that quickly before we move on to the next other point.
Yes, sir. Good morning, one and all. So, glycemic control is at the top priority, even with all the drugs, new drugs, or when some more new drug comes in the future. There is a mainstay around that. Everything builds around. So, whether the ADA puts it in other way or some other guidelines puts it in other way. So, second thing, usage of sulfonylureas. Sulfonylureas are going to stay, but the dosage which we use and the pattern which we use and at what point of time we initiate changes. So previously we were starting with say glimepiride 1 mg and 2 mg in a patients. Now the dosage changes. Low dose sulfonylurea, as I said, in patients particularly when HbA1c of 9 and 10, along with these newer molecules, we are using 3 or 4 classes of drugs. Probably low dose of sulfonylurea at the night, along with metformin, which completely makes the glycemic control very good. So that's where the perspective of usage of sulfonylureas changes. Or initially when we are waiting for this GLP-1 agonist to act or tirzepatide to act over a period of time, so 1 month, 1.5 months, and HbA1c is very high and the patient needs to lose weight, again that is a scenario where you need to use these drugs. And in specific scenarios like CLDs where HbA1c of 9 and 10, obviously these are the molecules that are going to depend upon, we are going to depend upon. The various patterns varies depending upon the creatinine and the CLD status, but these are the molecules we are going to depend upon. So how we look at it, or what are the molecules we look at it, and what forms we are looking at, whether we are looking at a prolonged release form or a short releasing form, like glycoside, so 40 mg, like how do you, the 30 mg, or how do you using this molecule in specific scenarios varies. But definitely it is a most previously when we are using this as a first preference, now we may be in second line or third line we are using it, but using it at lower dose. That's the way I look at it, sulfonylureas.
Thank you. Quick word from Dr. Rohini, and then we'll move on to other aspects.
Okay. Good morning, everyone. First, I would like to wish Happy Father's Day to all the fathers in the room here.
Happy?
Father's Day.
Oh yeah.
Today is Father's Day.
All the fathers in the audience here. I think it's.
So, in terms of using sulfonylureas, I think treatment has to be individualized. So, in my practice, definitely it's not the first choice. I would consider metformin, gliptins, if possible, SGLT2 inhibitors, and then introduce low-dose sulfonylureas.
Still used in how much of your practice? What percentage of your practice? What percentage of patients are on SUs?
I would say around like 20%.
20% only. Okay. So, I mean, it's a little different from what others are doing. Maybe I would say 50 to 60%, but you're saying 20%. Okay.
Yeah.
So that's nice. I mean, Dr. Rohini, quick word from you and then.
Yeah, sir. I mean, sulfonylureas are definitely here to stay. But again, the order of preference has definitely changed. And metformin and lifestyle is going to be like, the first step. But after that, depending on if the patient has CKD or proteinuria, SGLT2s, and then whether the patient is obese or like ASCVD or, CHF, GLP-1s and SGLT2s come first. And again, if there is a contraindication like a recurrent UTIs, I would probably not go towards SGLT2. And only after these two come the sulfonylurea. If I'm still not able to get the patient under control at the maximum tolerated doses of SGLT2 and GLP-1, then I would get the help of sulfonylurea for sure. So they are here to stay, but again, the order of preference has changed. And with the recent, manufacturing of semaglutide here in India, it's been game changer.
It's really changed,
so much more affordable to our population, and several people we can actually.
And it also probably depends on in your practice how many patients have how much duration of diabetes. If you have very long-standing patients, all of you, I mean, there'll be more people on sulfonylureas. If you have younger, I mean, patients with lesser duration of diabetes, probably you'll tend to have less of them on as use.
Correct.
So I think that also is so we'll move on to Dr. Srinivas and ask him about metformin. How does he use metformin? I mean, beyond the usual use in diabetes management, what are the various situations where you're using metformin?
Happy Yoga Day. Why my professor is asking me this question is, I always love old is gold. That's why metformin, Rakesh sir is asking that question about metformin. My always preferred drug is metformin. So if you write a prescription of metformin, 500 mg, 1000 mg, again patient will not come to you. So doctor has given a 500 mg, 1000 mg. So he'll go to somebody writes 1 mg, 2 mg. So then I will tell the patient that it's an anti-aging agent. So they'll say that, oh, so it's anti-aging? So then I will explain that. Oh, so out of the 4 drugs approved by FDA, one of the agent is metformin. So another entrance bit. Somebody wants to prepare for PG entrance. Out of 5 drugs, metformin is a anti-aging agent. So they will come again to me. So then I will tell that it's anti-cancer agent. Oh, then again they'll surprise. They're in the euphoria. So I will tell that suppose female is there, they'll say that endometrial carcinoma is one of the lot of studies are there. They're happy. So PCOD, anyway, young patient PCOD, I will say that PCOD one of the drug anyway we are using. So. And important is, recently there is one drug approved for an indication, is a age-related macular degeneration. So I think somebody has, only 2 weeks back it came in that it is one of the drug approved for age-related macular degeneration.
Oh, that's nice.
It is a 1960 drug. Why it is important is, youngsters should understand, it acts on the mitochondria. Mechanism of action is mitochondria, AMPK activator. What is AMPK? Nothing but ATP. What is ATP? Nothing but energy. But nothing but mitochondria. What is mitochondria? It's Atma. If you think about spiritual life, what is mitochondria? Nothing. It's just. So beyond our imagination, energy is there in the body, spiritual world, beyond our body. So mitochondria related to Atma. So think about Atma, think about mitochondria, think of metformin in diabetes.
Thank you, Dr. Srinivas.